So hello everybody, and welcome to the medical education program entitled Towards Personalized Care for People Living with HIV, Supporting Open Dialogue and Informed Treatment Choices. My name is Professor Jose Arribas. I'm the head of the Infectious Diseases Unit and Research Director of HIV and Infectious Diseases at La Paz Hospital in Madrid, in Spain. I'm delighted to have with me Mrs. Harriet Langanke, a journalist and sexologist based in Cologne, Germany. She's the founder of the GSSG Foundation and co-founder of the Germany's National Network Women and AIDS. She's also the program chair for combination prevention at the European AIDS Treatment Group. So we are going to start to have a conversation about a case. This 50-year-old man with HIV. He was diagnosed a long time ago, 25 years ago. He's in good control of the HIV infection. Current CD4 so count is 591. He's undetectable. He's taking a single pill with abacavir, 3-TC, dolutegravir, and he has been on this regimen for the last 5 years. He has no history of antiretroviral resistance or hepatitis B infection. Importantly, he has dyslipidemia and he's taking atorvastatin. He comes to the clinic concerned about recent weight gain with his BMI now in the overweight category. And he thinks his art might be the culprit. So this is a common issue now in our clinics. So Harriet, how do you think we should address his concerns about weight gain?
Yeah, thank you very much, Jose, for asking. I think the most important thing in the very first place is to really acknowledge his concern. I know that people, when they gain weight and see their doctors, sometimes the doctors, their physicians do not take it seriously, their concerns. They say, just, you're getting older, you're 50 by now, this is pretty normal. My personal approach would like to learn a bit more about what may have changed in his life beyond celebrating his 50th birthday, because it could be that there is also some other changes going on, and I would like to learn about that in addition to the laboratory data that you have already attend, I think.
So I think I agree completely, Harriet. I think as a doctor, we have to acknowledge and the importance that he gives to his weight change might be different from what you think is normal. So it's related to personal image, to your physical image. So I think it's very important to, as you said, to acknowledge his concern, because actually you have to reassure him that this is a very legitimate concern, and he comes with already hypothesis that this could be related to his antiretroviral therapy. And you have to admit that this is the case. In the HIV field, we are very worried about weight changes related to antiretroviral therapy. He's taking a drug that is related to weight gain. If you want to learn exactly what has happened, you have to go a little bit beyond antiretroviral therapy and have a global picture of what might be impacting in his weight. Do you agree, Harriet?
Absolutely. I absolutely agree. It's very important to find out more about his personal life, his psychosocial situation. So I would like to listen a bit more what this patient is sharing with us about what's going on in his life and how we could help him, because sometimes the simple change of a regimen in the therapy does not already lead to a loss of weight. So I think it's important to have the integrated approach here, a comprehensive approach.
So I think this is a great opportunity to make plans for this second part of his life, and I will try to adopt, a holistic view of all the things we can do, treatment related and non-treatment related, to have a very good health span for the rest of his life. I always insist in the importance of exercise, good diet, and then we get into the specific of the regimen. And I will acknowledge that he's in a regimen that is related to a weight increase, but also I will be quite transparent that so far changing regimens, changing antiretrovirals have not had a big impact on weight decrease. So I will try to be also quite honest about the expectations about weight loss, because that's something we know is difficult. I will probably recommend him to stop abacavir because of the high cardiovascular risk associated with abacavir. Those, I mean, these are a lot of information, Harry, and sometimes I worry that I overwhelm my patient with information. So probably we'll go step by step.
Absolutely. It can be overwhelming to get so much information, and I'm always encouraging patients to take with them a piece of paper and something to write, or ask the doctor whether they may record the recommendations so that they can listen to them again. And getting back to the specific patient, I think you mentioned a very important issue about his weight, because this is his main concern. And even if we change the regimen of his ART, it still needs some impact from his personal side if he wants to stop the gaining of more weight, or if he even wants to lose weight. So it's very important to understand that this is not happening just by changing, or losing weight is not just happening by changing medication, but he needs to have also more consciousness about his daily life and his lifestyle.
Okay, so it's very interesting. So let's ask the audience. Please tell us, what would you recommend in this case? So whenever there is secondary effect, or a worry about the patient is worried about if these drugs are doing something negative, is the issue of adherence, if he's having trouble with adherence because he fears is related to weight gain, and also that this is simple to switch. So next steps in this case, I think there are other two important points to make. That is, there are no history of prior biologic failures, so there are many options to switch in this case, because we are not compromising biological control. So I will stop abacavir, and then I have several options to switch. Yes, I can maintain only dolutegravir and 3TC, or I can switch to a regimen also including a second nucleoside. There could be other options, and I will need a longer conversation with the patient to explain him the pros and cons of its different regimens, because I have a lot to pick. So again, let's ask the audience. Please tell us, what would you recommend? So in terms of the next regimen for this patient, I would recommend to stop abacavir. And also I will inform the patient that current data does not support switching regimens exclusively because of weight gain, because the effect is so far has not been optimal. So it's true that dolutegravir has been associated with weight gain, but switching away from dolutegravir has not produced decreases. For example, when switching to a PI, we're waiting for studies to switch to another families of drugs like the NRTIs, like the doravirine. So we are waiting for those clinical trial results. And the other thing is that you have to switch to a regimen that will guarantee very good adherence. And I will stress again that switching the regimen is mainly because of the cardiovascular risk, is not for the weight changes. And I will stress again the importance of the importance of diet. So this case is a case that we encounter in the clinic almost every week, and it shows clearly all the details that we have to cover in these interactions, and emphasizes that managing HIV is a long-term partnership. We have to go for individualized care and balancing risk, benefits, and priorities. And we see that we have to have an holistic approach to this shared decision making. What are your final thoughts, Harriet?
I I'm very happy with the readjustment of the therapy. I think it's very important to check whether a new regimen really stops gaining weight and helps the patient with his well-being. I think it's very important to understand that even changing the regimen is not something like a silver bullet, and everything that he has gained on weight will just suddenly go out or off. So I think it's very important to have this comprehensive approach of adjusting the therapy and taking measurements regarding the lifestyle.
Thank you very much, Harriet. I think it has been a very interesting conversation. Hello, everybody, and welcome to the medical education program entitled Towards Personalized Care for People Living with HIV, supporting open dialogue and informed treatment choices. My name is Jose Arribas. I'm the head of the Infectious Diseases Unit and Research Director of HIV and Infectious Diseases at La Paz Hospital in Madrid, Spain. Joining me in this discussion is Mrs. Harriet Langanke, a journalist and sexologist based in Cologne, Germany. Welcome, Harriet.
Thank you for having me, Jose.
Our case is a 34-year-old woman with HIV diagnosed 4 years ago. Her HIV infection is well controlled. Her current CD4 cell count is 565, and her HIV RNA is undetectable. She's taking a single tablet regimen of Bictegravir/TAF FTC, and she's been on this regimen for 3 years. She has no history of R resistance or hepatitis B infection, and she's not taking any other medication. Her chief complaint is pill fatigue. So what is your immediate reaction, Harry? She's just taking one pill once a day.
My first thought, Jose, about this case is that I want to understand better what does she mean by pill fatigue? What's going on in her life that she is facing problems that she hasn't faced the other 3 years that she's on this regimen? So I would like to learn more about what this is that she describes as fatigue. Is it something that she experiences on a physical level or on a mental level? Is it something that is really bothering her because of something that is happening in her life? We have learned that she's in childbearing age. I would, for example, investigate whether she's also taking hormonal contraception. We are talking about one pill daily of HIV medication, and some people do not realize that hormonal contraception is also considered to be taking a pill. That's why I would like to investigate a bit further what's going on in her life and what is it that she really describes as her fatigue.
Okay, I completely agree, and I think it's very good that this person is open about it and has enough trust in her provider to acknowledge that despite it's taking one pill once a day, she is experiencing fatigue. To have a conversation, trying to get the details of what she means by pill fatigue, because we know that there are different issues with drugs, and also it's a very good opportunity to review if this concern has had an impact on her adherence to her medication, because just because the viral load is undetectable doesn't mean that between visits she might have some days of not taking the medication because this pill fatigue. And there are two different issues: is pill fatigue and pill burden. I like, to sometimes to compare this to, like, pill burden is like to have a very heavy backpack, and that's you have this burden, and fatigue is like going to work every day for the same route. Even if it's easy, you get fatigue of doing the same thing every day. So fatigue is more emotional exertion. Burden has to do more with physical difficulty with multiple or large pills. has practical challenges, and while fatigue, as you mentioned, Harriet, has to do more with the psychological impact. We're talking about still disease that is lifelong. Our patients have to be committed to take medications for their whole life. And this is a reminder also of an infection in people who otherwise feel completely right. Let's take a pause and ask the audience about this. I don't know, you have ideas, if we have this conversation with this patient, Harriet, about how to identify if it's more psychological or burden, because it's true, it's just one pill once a day.
Yeah, definitely. Some questions I would like to ask her is whether she is going with the same routine, taking her medication for the last 3 years, if she has taken it, let's say, each and every morning, and now she has taken on a new job and it doesn't fit anymore into her life. If she has established some routines that do not work anymore in her daily life. I would like to learn whether she has possibly a new partner that she doesn't want to disclose to in this early stage of a new partnership, where she tries to manage her medication in a more discreet environment. The better I understand what is the background of this fatigue or burden we are talking about, the better we can help her in adjusting the therapy. So yeah, I would like to ask those questions.
Right, and I think I don't know your experience, Harriet, but I think in order to decrease fatigue, I think one for me practical approach is to make it as a routine, a complete routine that you don't have to think about it. It's kind of reflex act that you don't spend even 3 seconds there. For example, you wake up in the morning, you just take your pill and get your breakfast or something like that. I think in my clinic in general that tends to work. If you have a very quick routine of taking your pills, and I completely agree. There are a new stressor like a new job or a new change in your shifts at work or things like that, I think that can have an impact.
There is one more point I would like to discuss with this patient is, given the fact that she's around her 30s birthday, she might also have some sort of wish to become a mom, to become pregnant. And maybe there is something in the background that interferes with this already established routines that remind her of being HIV positive. And so we could definitely ask her about if this is something that's going on in her life right now and that could be contributing to what she calls fatigue of taking her pill.
Okay, and also I will, inform this patient that there are now options that are not involved to take a pill every day. We have long-acting therapies. We have cabotegravir and rilpivirine intramuscular that can be given every 2 months. It's very nice that this patient has had no prior biologic failures, has no chronic hepatitis B infection. So definitely, long-acting therapy could be an option. That also it has pros and cons. Pros is that you don't have to take a pill every day. Cons, you have to go to the clinic every 2 months, and sometimes that can be also a problem. But I think it's an option, and it's an option that this person is really needs to know that to make decision. And this is something that in this situation can be absolutely tried. So let's ask the audience, how do you manage pill fatigue related to antiretroviral therapy? This case is also a very good example of shared decision making. I think it's very important with any complaint, talk about what matters most to the patient and how can we support the patient, whether you continue with your regimen or try injectables. I think uh, in our countries, we are fortunate enough that we have right now many options. We can inform the patient even Now, orally, we cannot go farther than 1 pill once a day, but there is active research on once weekly regimens. It's also that something that might be soon in our clinics. So we are fortunate that we can have different interventions to help this lady. So your thoughts about this also, Harriet, about this process of shared decision making with patients?
Once again, I think that listening to her explanation why she thinks that this pill fatigue is happening in her life can be very crucial for finding out what is really going to help her. Is this something that can be addressed by changing her therapy to the to a long-acting regimen? Or is there something going on in her life that needs to be addressed on a different level? Maybe even have her reflect on the situation in her daily life, in her routine, so that what you said about being a routine could help her in building a new routine for overcoming the fatigue.
Great, Harriet. So I will finish by saying that pill fatigue is a real and common experience, even for people on single tablet regimen. For the time being, further oral simplification is impossible, but we have long-acting injectables that might offer a very nice alternative for those seeking freedom from daily pills. I can't stress enough how important is in this context shared decision making and ongoing support to maintain adherence and quality of life for people living with HIV. So thanks a lot, Harry. That was a very nice conversation about this case.
Thank you very much, Jose.
Hello, everybody, and welcome to this medical education program entitled Towards Personalized Care for People Living with HIV, supporting open dialogue and informed treatment choices. My name is Jose Rivas. I'm the head of the Infectious Diseases Unit and Research Director of HIV and Infectious Diseases at La Paz Hospital in Madrid, Spain. Joining me in this discussion is Mrs. Harriet Langanke, a journalist and sexologist based in Cologne, Germany. Welcome, Harriet.
Thank you very much, Jose, for having me.
We are going to discuss a case. This is Lucas. He's 26-year-old, had newly diagnosed HIV. And unfortunately, as it's happening still in many countries, he presents really advanced. His current CD4 cell count is 190, and his HIV viral load is 265,000. He's not taking any medication and did not use PrEP. His hepatitis B status is negative. So we have a 26-year-old with this diagnosis very recently and with in an advanced situation with a CD4 cell count of less than 200 at risk for opportunistic infection and with a high viral load. So we need to talk about Lucas, about his HIV diagnosis and his options. So what will be your first goal in this interaction, Harriet, with Lucas?
My first approach to talk with Lucas about his HIV infection would be to learn whether he is part of some peer groups that he has already heard about, how it is living with HIV. And I find it very important because we see that he has quite a late diagnosis, so to say, that he may not have had access to the knowledge and to the, as you said, no access to PrEP. So I would like to learn whether we as, or you as his physician, as his doctor, whether we are the only source of knowledge for him, or if he already brings with him some misconception about not knowing about HIV, not knowing about what's going on with the body, how is the life cycle of HIV, and why it is so important for people living with HIV to get diagnosed, to have the opportunity for an early starting of therapy, because we want to avoid high viral loads and bad lab parameters.
I think that's critical, Harriet. I mean, as a clinician, I always feel the responsibility on this first interaction just to be good enough that the patient comes back. You know, that's, I think, is something that we have a lot to offer. You know, I always say that if we do things rightly, this patient will have the same life that he wanted to have, even with HIV, in terms of relationships, in terms of, you know, having children, or in terms of many other aspects. And I think it's very critical because even in 2025, as you said, Harriet, people come with information that is not, you know, real, or even conceptions that are still negative. And I always stress how much he has to gain by staying in the clinic, and by how wonderful antiretroviral therapy is. And also, I have to acknowledge, as informed, that he's in an advanced situation. Even if he's asymptomatic, he's at risk of opportunistic infections. Also, a new diagnosis of HIV is a great opportunity also to test for other STIs, other sexually transmitted infections. Also, I need to tell this patient that he needs to start prophylaxis for at least one opportunistic infection, PCP. Now, but I think it's very good in this type of interaction is, instead of going directly, you have to start treatment now, is what do you think, or what are your ideas about antiretroviral treatment, and see what he thinks. And then I have the opportunity to provide the information of what he can gain by starting antiretroviral therapy. But also, I think in 2025, we have this wonderful message that with a regimen in 2 months, he will be undetectable, and indetectable equals untransmissible. And that's, I mean, if I have to pick one of the messages that convince most of my patients to start therapy, that is a great message and something that we can be very positive about. Let's take a pause and ask the audience about this. So, in terms of recommendations for initiation of antiretroviral therapy, I think everywhere we will recommend to start with an integrase inhibitor-based regimen with either bictegravir or dolutegravir. We need to start also prophylaxis for PCP, and we need to screen for other STIs. In terms of what are the companions of dolutegravir or bictegravir, bictegravir can go with TAF and FTC in a single pill, or we can go with dolutegravir only with 3TC, or also with TAF, FTC dolutegravir, or TDF, FTC dolutegravir. We have several options here. I think it's important also when that we now recommend, patients need to know we recommend treatment for everybody. And in general, now regimens are are simple enough that we can start treatment very quickly, but always explaining patients also issues. You know how you approach to stress the importance of adherence, and how you manage to explain patients that it's important right now in 2025 to start treatment rapidly.
I definitely agree that it's a huge advantage to get the diagnosis in 2025 other than in 1995. And it's very important to explain this advantage to people who do not have access to the knowledge that we have, who still believe that this is some sort of death sentence, which is still quite prevalent in many communities. And talking about communities, I would like to recommend to this patient to look out, to search and go for counseling, to find peers, to find psychosocial counseling in order to learn how to live with a chronic condition like HIV has become during the last decades, and to really have the full benefits of what ART medication can achieve for him. So it's not that we are the only addresses, you as a doctor, physician, or the general practitioner are his only addresses of learning about living with HIV, but also people who are trained to tell him how to address this chronic disease, this chronic condition, and how to avoid getting symptoms, and how beneficial the adherence to the therapy can be for his life.
Great. So, obviously, in this first interaction, we go about other issues like a full physical exam, full medical history, any symptoms of complaints, STI testing. Also, is very important because this is still overwhelming. I agree with Harriet. It's a disease we cannot cure for the time being, and this is a lifelong disease. But this is a very important life event for our patients, I think. And you have to digest the diagnosis. Sometimes they are worried also about information for partners. I'm very open. They need to take their time, but if they want to bring partners to the clinic to hear from me what is HIV in this time, I'm always open to do that. And I think support, as you mentioned, Harriet, is critical. And also, in terms, I went directly to the regimens he can take, but before doing that, I always have to have a very good picture of how his life looks like in terms of job, in terms of times, in terms of issues that can have an impact on the regimen that I would recommend. So let's ask the obvious. How quickly would you begin therapy for Lucas? Again, is an advanced HIV infection recently diagnosed, another important moment for shared decision making. And I think we have to be open. We are very convinced about the importance of starting treatment. WHO recommends in general in 1 week, but always we have, if we want to be successful, we know we need to have the patient feelings about starting treatment and the preferences for pills, for number of pills or timing. Your final thoughts, Harriet, about starting treatment?
I liked very much that you addressed the sexual health issues in your talk, because I think seeing a young man, seeing a young patient here who we do not know what this person knows about HIV, I think it's very, very important to talk with him about how to maintain his sexual health, how to deal with HIV is just one sexually transmitted infection, how to protect himself, how to increase or address at least the sexual health issues. So I find these very important. And to repeat, I think it's very important for someone who just got diagnosed to learn from other people living with HIV that this chronic condition can be dealt with thanks to the modern ART regimens we have at hand.
So thank you, Harriet. My final thought on this case is that rapid art initiation combined with holistic psychosocial and preventive care approach really can optimize outcomes for patients even with advanced HIV infection. I think this is a very good message that even in this situation, we have a lot to offer to our patients. So thank you very much, Harriet.
Thank you so much, Jose, for having me. And it's a great pleasure to share with you the different perspectives we have when it comes to living with HIV and dealing with HIV regarding ART and medical issues.